Thank you. Happy New Year and welcome to our first meeting for 2025, for sure, for the Alamo chapter. And the approval of the minutes, they are on your table. Please look at it during the section, approval of the minutes. I think we have a motion for approval. Thank you. Is there a second? There is a second. Everybody wants to second. Is anybody against approval of the minutes? Hearing none, seeing none, the minutes are approved. Officers report, one of the biggest reports we have is of course our treasurer's report. It is on their agenda. Our current bank balance as of January 24th, 2025 is $46,307 and some. So, but we are financially very healthy. We have CDs that we have put in for our reserve, and we're very well financially. Anybody have any questions from that perspective? Hearing none, seeing none. Next is our announcements. There's two announcements. This is actually a very important meeting, and so over the next month's one. Our Alamo chapter officer nominations and elections. We do a different cycle. It's not a calendar year cycle. We accept nominations till the end of this month, actually. And then next month's meeting is the election of those nominations. It is chaired, that committee is chaired by Dr. Michelle Avery. So Dr. Avery, say hi to everybody. If anybody's interested. We have positions of president-elect, vice president, secretary, and treasurer. Thus far, I believe we have nominations for each one of those positions. If anybody else is interested, please let us know. And especially either let me know, Dr. Avery know, or let Samantha know, because those nominations are open right now. So if you have anybody else who's interested, please let us know. Our election of office, the election will be at the next meeting. It is on February 25th, 2025, at this next meeting right here. Okay. Anybody have questions on the process? And then they are installed at the March meeting. So that's why I said our we do not follow a calendar year. It is actually all, and the old officer like me says thank you so much and say bye. Okay. Anybody have any questions on that process? Nope. Okay. Our next meeting is on your agenda. That will be on February 25th. This is the location. It is at 7 p.m. Dr. Nguyen will be giving us the presentation at that time. No other questions? I want to make sure we give more than adequate time for our program. Yes, ma'am. Yes, the interim session is in April. Interim session, TAFP interim session is in April, and we do call for delegates. There's if you are interested in going there, please let us know. Again, that is something that we ask you to let Samantha know, so that we can get a full slate. We have 7 slates that we will sponsor, and so please let us know if you're interested in being a delegate. Okay. Anything else? Yes, ma'am. Okay. Yeah. Yes, 3 members from 3 different commissions, so we're very well represented. I said it's a submission of health, the public, and science, and something that's really interesting me is that do physicians get free insurance from the AA who the first year out of practice? And I remember this much. I think it's life insurance for the year because they understand how it is to graduate job.
The Division for Continuing Professional Development, which is in charge of CME overall. And so basically, we kind of uphold the standards and set the standards for what it counts as CME for the AAM. So. And then Dr. Nguyen is on education.
Now, I just want to thank them all for their service, all of their work. They all we work really hard to get our practice interests and to issue policies and procedures to make sure this is well done. Thank you, all three of you, for serving. Quite a thing to have Alamo representation for there. Okay, any other announcements? Okay, if not, then we're going to go on to the program. We have actually Mary who's going to talk to us. She's going to talk to us about qualifying conditions for medical cannabis in Texas. I'm personally quite excited about hearing about this. I've been waiting. We've been waiting to have the CMA for some time. So we're very excited to hear about this, and I'm going to send it over to her because I want to make sure we have that. Based on the audience, I have a feeling you're going to have some questions. And I think you did the same thing.
All right, thank you for joining us tonight for this edition of the South Texas Regional Family Medicine Grand Rounds. Thank you in advance for being attentive to the presenter and engaged in the session, and for registering for CME credit for each session, and then for completing and submitting a session evaluation form. Today is January 28th, 2025, and today's session code is 1009-6272. You can claim credit via the instructions on the screen. FAAFP members can use that login and claim credit for this activity online at the link on the screen. This live activity, the South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to 1 prescribed credit by the FAAFP, and physicians should only claim the credit commensurate with their extent of participation in the activity. These are the physician core competencies that our Grand Rounds address. And then I'll hand it over to Dr. Nguyen. You want to walk?
Oh, thank you. Good evening, everyone. I'm going to talk about qualifying conditions for medical cannabis in the state of Texas. Figure out how this works. So the objectives of this lecture are, after reviewing the presentation, you should be able to identify conditions which may qualify a resident in the state of Texas to receive a prescription for medical cannabis from a certified provider, construct and implement therapeutic protocols that utilize cannabis as a core facet of patient treatment for qualifying conditions in the state of Texas better, identify contraindications that would prevent a patient from receiving medical cannabis. Here are my whys. We have 6 kids, but these are our 2 youngest. The picture on your left is a 7-year-old Jonathan. And what's surprising about this picture is that at this age, Jonathan only wore a short sleeve red shirt. It had to be red, full on jeans, and that's it. We could not get him in long sleeve shirts. We could not get him in jackets. That's what he had to wear. One morning, I think I fought with him for 45 minutes to try to put on a jacket, and then I just gave up. And Lloyd can testify because Lloyd's also combated with him, and it's amazing how strong the 7-year-old can be. So having him dress in a long sleeve gown was amazing. that his therapist was able to do it. And again, having him wear a cap is another amazing thing because he refused to have anything on his head. He hated it. It was a sensory issue. And then trying to get him to smile in a picture was impossible because he didn't realize that he was a person because he didn't have self-awareness. We had to take, the only time actually I was able to get him to smile was I would tickle him and then Lloyd would take a picture, and vice versa. The other picture is about 2 years old. He was only about 6'3" at that time. He's currently 6'5¼ and he wears a size 15 shoe. And his sister, who's in that picture with him, is 4'10" and about 100 pounds. So he was doing fine, going through therapies, taking his medications, and then puberty hit. And then he became a raging individual to the point where we thought about committing him because he was a danger to himself and to us. And if you can imagine having a 6'5", 200-pound man-child running at you, ready to hit you, is pretty scary. And I think I called Lloyd home almost every day for months, trying to figure out what to do. His psychiatrist and we worked together. He gave him enough meds to knock over an elephant, and he wouldn't sleep, and his medicines would lower his seizure threshold, which he never had seizures before, but he developed 2 seizures out of the blue, so that was scary. And I finally did some research, and I asked his psychiatrist, what do you think about cannabis? Because I don't know what else to put him on. You name it, we tried it. Benzodiazepines, psychotropics, antidepressants, anti-anxiety medicines. Nothing worked for this child. And he was a child. He functioned about 7 years old. And we started very slowly, of course, which was recommended. There weren't really a lot of information at the time, and it's made a world of difference. We've been able to wean him off of some of his meds. He takes 5 milligrams of THC twice a day with 100 milligrams of CBD. And he's the reason why I decided to get my master's degree in medical cannabis science and therapeutics. So some basic definitions. When I first started, I was terribly confused by all the words out there: cannabidol, cannabis, delta 8, delta 9, delta 10, trying to figure out what these all meant. So these are just basic definitions. And the one you really need to know are the endocannabinoids, which is, we have an endocannabinoid system in our body, and there are 2 natural endocannabinoids, AEA and 2GA. And the phytocannabinoids are actually the chemicals that are derived from plants, cannabis sativa in particular, and the extract is what interacts with the human ECS. There's over 100 of them, and we're not sure how they affect the human body. We know some things about some of them, but again, because it's difficult to do any sort of meaningful research on an illegal substance, and therefore a lot of what we do know are very small in number and anecdotal, because if you can imagine, if you're given THC and you're in the placebo, you know you're in the placebo. So it's been very difficult to find good studies on it, even from other countries where cannabis is legal. And of course, THC and CBD are the 2 most common phytocannabinoids that we talk about today. So in order to get medical cannabis prescribed to you in the state of Texas, a qualified physician has to determine if the risk of medical low-dose THC is beneficial in light of harm. Again, just what we do every day, benefits versus risk. And who can receive cannabis prescription in Texas? These are the only qualifying conditions. And as you notice, anxiety is not on there, which is the #1 reason why my patients say they take cannabis for their anxiety. So epilepsy or seizure, MS, spasticity, ALS, autism, PTSD, terminal cancer, and incurable neurodegenerative disorder. By law, Texas medical cannabis dispensaries may sell low THC cannabis products that contain no more than 1% by weight of tetrahydrocannabinols. Tinctures and oils containing 1% or 10 milligrams per ml of THC are available in edibles. I usually prefer tinctures because then you can mix them with other substances and you can also control how much the patient is actually getting. Cannabis plants that contain less than 0.3% of THC are categorized as hemp. And as you know, hemp is federally legal. And that's what you see. You can walk out in the street now and probably see a cannabis store on every corner. And what's amazing to me is they'll say free CBD and free marijuana and free THC, which I'm not sure how they can publicize that because THC is still illegal recreationally in the state of Texas and federally. So again, I'm not sure what they put in it. You do have to be careful about how they produce the hemp because even though it's legal, if it has less than 0.3% of THC, and that's the magic number, 0.3% or less, you don't know what else they mix in it. And when they've tested hemp, there's been formaldehyde, substances that we don't recognize. So there's many, many things. It's just like with everything over the counter that patients buy, and they come in and they say, can you tell me if this is safe? They say to ask my doctor, and you ask them, well, what's in it? You kind of have an idea, but you can't always figure out what's in the substance. So please caution your patients to not buy anything that hasn't been tested or isn't purchased as a medical cannabis. How many DPS dispensaries are there in Texas? There's currently 3 that are qualified, and the Texas Department of Public Safety, or DPS, approves those 3. Texas is known as a vertical state, which means that in order to be a dispensary, you have to grow the plant, produce it, manufacture it, and then take it out to patients. So let's say you have a dispensary in San Antonio, but you want to be able to sell to Dallas, patients in Dallas. You then have to drive your product to Dallas and then find a place where the patient can pick it up, and that location then has to collect the money. It cannot be paid for by credit card because it's federally illegal, so it has to be cash or a check. And by the end of the day, you would have to drive it back to San Antonio in order to store it because legally you have to store it in only one location. So it's extremely expensive to get a dispensary, and then DPS is very particular about the laws and the rules. And so that's why we only have 3 dispensaries in the state of Texas, and they've pretty much halted any new applications. For some reason, the working group that manages the suit DPS has decided not to approve the dispensaries, and other states and other companies have been trying to get into Texas. These are the 3 for reference, and if you want, just ask Samantha, I can give her the slides, and that way you can figure out which one. And again, it's up to the patient where they would like to go. The process to obtain medical cannabis in Texas, the Compassionate Use Program in Texas, or CURT, was first approved in 2015, and it allowed for the first legal use of low THC cannabis products for patients with intractable epilepsy, and then it was expanded to 2019 and 2021 to include other conditions. The last one is PTSD, and that was through the work of our veterans. To be added to the medical marijuana registry, you have to be a Texas resident. You have to have a qualifying medical condition as determined by law, and you have to be evaluated and obtain a prescription from a qualified physician who's registered with the state to prescribe cannabis. So those are the guidelines. They're not super strict. So if you go to DPS to try to become a certified provider, you just apply, but you have no idea what the certification process is, because I've gone to their site to try to figure out what the guidelines are, and there really isn't one. They basically say, if you're a physician who practices in the state of Texas, obviously licensed physician, and you manage these conditions. They don't say how many you manage, how big is your practice, how many patients you have that have these conditions. So you don't know, if you do get certified, you don't know why. And if you don't, you don't know why. And just for reference, I know a adolescent, a psychiatrist who was not able to get certified, but then I was able to get certified. And currently there's over 100,000 physicians in the state of Texas. I'm sorry, 800 or so by the end of December of last year, and over 100,000 patients on the CURT process program. Once approved, the doctor will add the prescription to the CURT dispensary, which then basically it's DPS. DPS then gives it to the 3 different dispensaries, and then you can call any of the 3. They will all have your prescriptions because it's all done online. There's no card, there's no written prescription, everything's done online. So let's say you get stopped by a police officer and you happen to have your medical cannabis. they can look for you under the DPS system and see that you're qualified to have the prescription, and therefore it will be legal for you. How long is a medical cannabis prescription valid? Texas is different because we don't really require an annual renewal of medical cannabis registration. It depends on the physician. So for me, I usually like, because it's controlled medicine, I like to see the patient usually within a month, sooner if they have questions or problems, and then every 3 months, just like we do with our patients on controlled medicine. But in Texas, you only have to see them maybe once a month in order for them to get a renewal of their prescription, since it's all done online. So medical marijuana approval in Texas is considered an ongoing journey of care, not bound by time, but by the benefit to patients. So that's why there's no regulation on how often you have to see the patient, any testing you have to do. Again, because my patients, I know them, I just see them every 3 months for their routine follow-up. I do their drug screen. Make sure there's no contraindications or problems that they may be having. Can patients fill marijuana prescriptions outside of Texas? The short answer is no. When you get on the PERT program, the only places that you can get medical cannabis is through the 3 dispensaries. So question 1, I'm visiting Texas and would like to purchase medical cannabis at a Texas dispensary. Will a Texas dispensary honor an out-of-state medical cannabis card? 1, yes, Texas honors all out-of-state medical cannabis cards at their state dispensaries. 2, no, only legal residents of Texas on the CURT registry may purchase medical cannabis with a prescription from an authorized Texas physician. And of course, the answer is 2. So only Texas residents on the CURT registry may purchase medical cannabis in the state of Texas. And even if you have a card from another state, and you're using it for, let's say, epilepsy, you cannot purchase medical cannabis in the state of Texas. HUP approved indication and suggestions for therapies. Epilepsy was the first condition that had FDA approval for a cannabis-derived treatment. Epilex treats seizures associated with LGS, DS, Stargardt syndrome, or tuberous sclerosis complex in patients of 1 year of age or older. So in the state of Texas, the physicians that were able to get certified first were pretty much all neurologists. 5 significant randomized double-blind multi-center clinical trials evaluate the use of CBD in patients with LGS and DS, and all of them showed reduced seizure frequency, the most common side effects as you see with most medications: somnolence, fatigue, rash, decreased appetite, diarrhea, insomnia, and elevated liver functions. And again, very common with a lot of the medications we already prescribe our patients. This is a table that shows 4 major studies on the use of CBD or Epidiolex in reducing seizures. And all the studies showed that. I'm sorry, it's so small. Again, if you'd like a copy of the study, I'm happy to provide that. Dosing, you want to start at 2.5 milligrams per kilogram twice a day. And then depending on tolerance and response, you can increase it to 10 milligrams per kilograms twice a day. Most physicians are comfortable prescribing FDA-approved medication rather than arsenal CBD products due to standardization of manufacturing techniques. Because if you go look at CBD, even if they say it's from the same manufacturer, if you tested them, they have very inconsistent products. So even though they say this much CBD is in this bottle, and even though it comes from the same lot, same manufacturer, they can still have wide variations. So again, it's recommended work with the patient's neurologist to evaluate treatments with cannabis if the patient does decide to start cannabis. I usually call the neurologist, or I have my patients tell their neurologist that they're interested in starting cannabis therapy so that the neurologist is on board. And most of the time, they're perfectly fine with medications. And then I've been able to reduce some of their seizure medications due to their THC and CBD. All right, this is the next question. So TM has a 3-year-old daughter diagnosed with Lennox-Gastaut syndrome who's stabilized on Epidiolex, valproic acid, and felmimate. TM has recently met a friend who makes their own CBD tincture and has offered it to TM as an all-natural alternative to Epidiolex. TM comes to you asking if she can substitute her friend's artisanal tincture for her prescription of Epidiolex. One, no, there's no guarantee what might be in her friend's tincture. And two, yes, CBD is easily extracted from hemp and concentration does not matter. Of course, the answer is no, because again, depending on how it's manufactured, there is a heating point to where once you overheat the plant, it's no longer efficacious. So again, there's something called terpenes, which I know you've all heard. Terpenes are basically the substance in the plant that gives it its flavor and its color. There's hundreds of them. There's some that are uppers and some that are downers. And we honestly don't know all of them, how they work, but there are a few that are well known. So that's something else that patients don't know about when they produce an over-the-counter CBD product or a THC product, what is exactly added in it. Because you probably heard some patients say, Doc, I took this CBD and it said it was supposed to relax me and I couldn't sleep. I felt terrible. I felt anxious. And again, I would ask them, well, do you know the terpenes in them? And they would say, well, what is that? And I don't know if you've ever looked at the labeling on these products. I can't read them. They're really small, fuzzy, and it's almost like they don't want you to know what's inside them. And that's just not one, rare instance. I've asked my patients to bring it in because I tell all my patients, please bring in all your medicines when you come in, things that you take over the counter, things you don't think that are important, please bring them in when I see you. And I have a very difficult time trying to figure out what's in their CBD or their hemp. And of course they can get it because it's considered legal. MS, spasticity, and ALS are all related in that they're neurological disorders that are caused by damage to neurons. And the symptoms are very similar. So there was a compound that was developed in the UK called Stivix, and it's a blend of CBD and THC with small amounts of other cannabinoids and terpenes that were extracted. And it's an oral mucosal spray. It's seen to cause or reduce spasticity and neuropathic pain in patients with MS who have not responded adequately to traditional medication. It's a stepwise dosing with a maximum of 12 sprays per day. Anything above 12 is not recommended, and this is not available in the US. It's available in Canada and in the UK. Marinol is a synthetic version of trans 9 THC. And the difference, because I know I got confused when I would hear Delta 8, Delta 9, Delta 10. What does that all mean? So Delta 8 is currently legal, but with the new farm bill, they're looking at making it illegal because there are psychotropic effects of it, because there is some THC, even though it's supposed to be less than 0.3%. So there's a particular congresswoman who's very anti-Delta and wants it off the farm bill. And Delta 10 is also considered a hemp product. So again, not the high doses of THC. And then Delta 9 THC is the actual psychotropic agent. So 8 is supposed to be okay, 10 is supposed to be okay, 9 is illegal. So that's where you hear those numbers, because I know I got really confused when I would hear patients talk about Delta 8, Delta 10, Delta 9. So Marinol is highly effective in the treatment of pain and sleep in MS patients, and its weight-adjusted dose of 0.25 milligrams per kilogram with a maximum of 25 milligrams per day. And the brand name has been discontinued, but there is the generic version still available. Sesamet is a synthetic analog of Delta 9 THC, and it was approved in 1985 for chemotherapy-induced nausea and vomiting, and later approved for the treatment of neuropathic pain and chronic pain, as well as MS spasticity. There are 3 doses. It's 0.25, 0.5, and 1 milligram. And it's recommended to start at 1 milligram a day, which seems to be beneficial in reducing most of MS symptoms. And this was discontinued in 2019. And I don't really know why it was discontinued. The only thing I can find is I think it was a cost factor, because a lot of these medications are not approved by insurances. They would pay for them, but they would be extremely expensive, as you can imagine. Common side effects reported with treatments, very common that you see with pretty much every medication we give our patients: dizziness, fatigue, drowsiness, vertigo, and dry mouth. Dosing THC and CBD for MS and ALS related spasticity and pain. Studies showing that starting at 1 milligram per day and increasing stepwise to efficacy of tolerance up to 10 milligrams per day were studied. And the higher dose up to 30 milligram per day of THC, if combined with CBD, seems to not cause the psychotropic effects as if you were just giving straight THC. So if there's a combined product, higher doses of THC tends to not cause us many problems if you use it with CBD, since CBD tends to attenuate THC effects and decreasing the psychotropic effects of THC. So CBD dosing up to 1,500 milligrams by mouth daily have been well tolerated. One study I read on monkeys, they dosed the monkeys at, I believe, 8,000 milligrams of CBD a day with no side effects, and there have been no reported overdose cases with CBD. So there hasn't been any toxic effects, overdose effects, or any abuse when it comes to CBD use. Autism spectrum disorder. Studies have shown that cannabis products reduce the number and or intensity of different symptoms and behaviors such as hyperactivity, restlessness, anxiety, episodes of self-interest behavior, anger, anxiety, irritability, sleep disturbances, and perseverance. Also noted were improvements in cognition, attention, sensory sensitivity, social interaction, and language. And the most common side effects, as you've seen again, as you can see, sleep orders, nervousness, and a change in appetite. Why does cannabis help in ASD? Most there's possibly a dysregulated endocannabinoid system that plays a role in patients with ASD. And the mechanism of action may involve GABA and glutamate transmission regulation. And CBD then is used to play seems to play a role in decreasing anxiety. Following THC administration, patients reported lower rates of anxiety, distress, and depression, as well as improved mood and better quality of life. Dosing of CBD and THC in children with ASD, and since about children, because most of the time that's where the medication is mostly needed. Usually daily dosing of CBD in one study was 16 milligrams per kilogram with a maximum dose of 600 milligrams. And THC starting at 0.8 milligrams per kilogram with a maximum daily dose of 40 milligrams. And in most studies, anything over 40 milligrams of THC tends to cause worse side effects, and all you have to do is lower the dose. Is usually within 24 hours, the side effects are gone. PTSD, research suggests that changes in the endocannabinoid system resulting in stress hormone that causes dysregulation plays a role in PTSD. And CB1 receptors in the amygdala is where THC interacts, and it seems to reduce the reactivity in the amygdala. So there are two endocannabinoid receptors in the body. There's CB1, which is mostly in the brain, and CB2, which is mostly in the body. You can find both in both places, but CB1 is the receptor that binds mostly with THC that causes the psychotropic effects. THC may increase connectivity between the amygdala and prefrontal cortex, impacting fear processing. Patients with PTSD are increased risk for substance abuse, and this is why our veterans really fought hard to add PTSD as one of the qualifying diagnoses, because as you know, a lot of my PTSD patients self-medicate with alcohol, smoking, different sorts of things, other sorts of drugs. And there's no single instrument that's been universally accepted as the best tool for screening for cannabis use disorder. And so again, it's, talk to your patients is what we do best. Just sit down and talk to your patients in a non-judgmental way. And I had one patient who tried everything and she admitted to it. And she said she had not been able to sleep through the night. I started her on THC. She actually drove to Austin to a dispensary because she didn't want to wait for them to deliver it. And I saw her back in a week because I was worried since she had this history of substance abuse. And she said for the first time in her life, she was able to sleep through the night. Even though she woke up, it was not with fear, she was able to fall back asleep. So it's helped a lot of patients, and that's why PTSD is now a qualifying condition. These are some screening tools, but again, there's no one particular tool that's best for screening cannabis abuse in patients. Medical cannabis and PTSD, we know it acts as a partial agonist at CB1 receptors, but there are really no defined, well-studied, double-blinded clinical trials that tell us the exact role of cannabinoids and how it interacts in patients with PTSD. We know there's a list of receptors there. We know that it targets these receptors. We know that CBD1 specifically binds to THC. CBD itself, we're not sure how it works because it doesn't bind the way THC does. It tends to attenuate other receptors and other medications. So, for instance, it's been shown to augment SSRI medications so that they work better. And again, we just need more studies. Cannabis and terminal cancer has been used. Cannabis has been used for pain, anxiety, and depression, chemotherapy-induced nausea and vomiting, anorexia and cachexia, as well as sleep and terminal cancer. As you know, cancer pain is complex. There's a neuropathic component, which deals with encroachment on the nerves. And there's a nociceptive component, which is visceral somatic pain and very difficult to treat. As 90% of all cancer patients, and it's one of the most feared and debilitating symptoms of the disease. Cancer pain is often chronic and inflammatory, nociceptive, and neuropathic. Studies have shown that smoked or vaporized inhaled cannabis was helpful for treating neuropathic pain, and they use smoking or vaporizing because the result is pretty instantaneous. It doesn't have to go through the first pass metabolism of the liver. And so those with chronic cancer pain were given cannabis in order to control their pain. As early as 1975, there was a small 10-patient placebo-controlled crossover dose-finding study finding that 10 milligrams of THC provided more relief than a placebo. And a subsequent study with 36 patients demonstrated that 10 milligram THC produced a comparable amount of pain relief as compared to 60 milligram of codeine and comparable sedation to 120 milligrams of codeine. A 3-week Canadian cohort studying using nabiximols on advanced cancer pain in patients already optimized on opioids demonstrated improved average pain score. And a large observational study of cancer patients using cannabis over 6 months demonstrated a decrease in the number of patients reporting severe pain, and noted patients reduced their opioid use over the study. So cannabis and anxiety and depression in cancer patients, unfortunately, the data isn't very clear on the role of cannabis in relieving anxiety and depression. We know at low doses, THC does help with anxiety, but at higher doses, as I've discussed, anything over 40 milligrams tends to increase anxiety. There was a study done on CBD on anxiety in public speaking, and there was positive response with CBD alone. THC alone didn't really help with anxiety, with public speaking, and the combination helped, but not as well as CBD alone. In 1992, the Materia Medica gave indications for cannabis use. This was in the US Pharmacopoeia into the 1930s. Cannabis was recommended for marked nervous depression, insomnia with brief periods of sleep disturbed by unpleasant dreams, and spasmodic and painful conditions with depression. Chemotherapy-induced nausea and vomiting, or CINV, can be controlled with aggressive pre-medication specific to each chemotherapy regimen. And there's a classification that's listed there. So to determine what's considered high, moderate, low, and minimal, to categorize what kind of medications should be given to the patients or pre-medicated before the chemotherapy. And acute CINV occurs within 24 hours of initiation chemotherapy, and it involves the receptors in the GI tract. And the 1 to 5 days later is mediated by receptors in the brain. Patients treated in accordance with guideline recommendations by the Multinational Association of Supportive Care in Cancer were significantly more likely to complete their treatment with no nausea or vomiting and no use of rescue therapy. So the reasons cited for inadequate pretreatment for CINV, physicians lack adherence to anti-emesis guidelines. Patients underestimate how severe their CINV is, and so they don't accurately pre-treat. And then cost is very high. Patients like to wait until it occurs before they address with medication, whereas we recommend patients pre-medicating. And up to 32% of patients may experience a disruption in their scheduled chemotherapy due to adverse events related to nausea and vomiting. So JR is a 45-year-old male currently undergoing treatment for oropharyngeal cancer in San Antonio. He's advised by his nausea. He's receiving cisplatin known to be rated as highly emetogenic. What areas for this patient's antiemetic prophylaxis before recommending medical cannabis? A, is patient being given prescriptions to fill ahead to prepare for chemotherapy? B, does the patient have insurance that covers his prophylactic medications? C, can he afford the copays if he does have insurance coverage for his prescriptions? D, all of the above. And of course, it's all like the above. So treatment for CINV with cannabis, again, there's not a lot of to the end. So we're not sure if the data is accurate because they took the medication too late. So again, there still needs to be lots of studies. Anorexia and cachexia in cancer. So cachexia is a syndrome characterized by ongoing skeletal muscle mass loss that cannot be reversed even with nutritional support, and it's progressive in nature. It's estimated that 22% of cancer deaths are related to cachexia, whereas anorexia is described as a loss or reduction in appetite. And a study of 1,115 colorectal and lung cancer patients showed that patients with anorexia had lower survival rates and showed more adverse effects than patients who maintained their appetites. So there are 2 medications for the treatment of anorexia, cachexia in the US. Less than 30% of patients experience short-term appetite stimulation. So the medicines don't really work well for the patients. Although weight and appetite might improve, there's no increase in quality of life or survival. An increased inflammatory environment, like present in advanced cancer, promotes lean muscle mass loss. And there are 3 inflammatory cytokines responsible for this: TNF alpha, interleukin-1, and interleukin-6. And THC has been shown to reduce TNF alpha, and cytokines impact the endocannabinoid system through their interactions with CB2 receptors, which may be upregulated in the presence of interleukin-6 and TNF alpha. So what we think that helps with cachexia and anorexia is THC reducing the TNF alpha, which hopefully will improve symptoms. Overall, there's a positive finding for use of cannabinoids for anorexia and cachexia in cancer patients. But again, evidence is variable soundness and more investigative work needs to be completed. And as you can see throughout my slides, we just need more research. The majority of trials find no significant adverse effects associated with cannabis in this patient population that aren't relieved by decreasing the dose of cannabinoids. So again, if there are side effects that patients can't tolerate, decrease the dose, even stop it for 24 hours, and usually the symptoms resolve by then. Medical cannabis for sleep in patients with cancer. As you know, most of our cancer patients have poor sleep, and medications may play a role in stimulation of the central nervous system from corticosteroids to use in CINV prophylaxis. One small trial reported that medical cannabis improved cancer patient sleep initiation, sleep continuity, and decreased participants' need for sleep medication. So you notice I've said over and over, there's just not enough data, and that's because you can't do good research on an illegal drug. And again, there's not a good placebo. So we had a test group and a placebo group. You pretty much know right away after first dose, especially if you're THC naive, which medication you received. One of my professors did mention that there is a new placebo that has similar effects to THC. So that's very optimistic. And you probably also heard about the reclassification of THC from a class 1 to a class 3. The DEA is still working on that. Just because it gets reclassified to class 3 does not mean that it is legal. What it does mean is, one, we can then do research on it. And two, it'll help our dispensaries, because currently, since it's not FDA approved, nor is it federally legal, a lot of the dispensaries, and a lot of the businesses cannot borrow money from FDIC guaranteed banks because of the regulations. I've talked to, even in California and Colorado, I've talked to other professionals there. And they said that it was extremely difficult. They had to go to smaller banks and that required bigger deposits, and they had higher fees, and none of their business expenses were tax deductible. So that would, of course, then help dispensaries and hopefully open more dispensaries so that patients can get medical grade cannabis. So for medical use, optimal amount of CBD may vary, and again, 15 milligrams or higher is well tolerated with no psychoactive active effects, and the dosing range is very liberal. THC should start at 1 milligram per day. Consider 2 taken at bedtime for sleep, but of course, always start low and go slow is our mantra. And of course, increase stepwise gradually as tolerated with a maximum of 40 milligrams a day, because anything over 40 milligrams has not shown benefit, and it just increases side effects. Again, side effects: drowsiness, sedation, dry mouth. Start low, go slow, increase every 2 to 3 days. I tell my patients to keep a daily diary, put what they're taking, how much they're taking, positive and negative effects. And I'm on call 24/7. So I tell them if they have a problem to call me, because if they go somewhere else, they get the looks. I'm just going to put it that way. And then, of course, everybody starts lecturing them about the use of cannabis. So I just tell them to call me, and we can adjust their medications. And of course, if you reduce the dose, if you notice side effects, usually the side effects would disappear within 24 hours. So general guidelines: screen for precautions, contraindications. Again, depending on what the patient's medical history is, you obviously don't want to debate if they have lung issues. It's contraindicated in pregnancy and breastfeeding. And if there's a strong family history of psychosis or bipolar disease, you don't want to initiate THC. You want to, of course, discuss patient risk factors, establish measurable goals of therapy, monitor regularly, and adjust dosage for adverse effects or medication changes. Edible cannabinoids travel, again, first to your stomach and your liver. So all the edibles take anywhere between 30 minutes to 2 hours before you'll see effects. So something to counsel your patients, because what they'll do is they'll take it and they'll go, I don't feel anything. So they take another one. I don't feel anything. So they take another one. And so I have to tell them, give it an hour, wait. And then instead of a full dose, take half a dose and see how you feel. Wait a couple hours. And sublingual tends to work quicker in 10 to 30 minutes. But it's hard because even though it's sublingual, most people swallow half of it. So again, I tell them, please wait an hour and give yourself a couple of days. It's not a magic medication. Take your time. Be sure that your patient has the strength and dexterity to manipulate the container. The way it's in a vial with a dropper, and patients don't think anything about it. They think droppers are accurate. And if you've ever used a dropper, you know it is probably one of the most inaccurate ways to give yourself medications. And some of them literally just go, I just squeeze it like this and put it in my mouth. And I tell them, well, what exactly dosing are you doing? And they say, I don't know, it goes up to the 1, right? Well, you know, you can squeeze it and it can go past the 1 milligram or the highest dose. So I tell them, please use a syringe. You can read it better. You can monitor how much you give yourself and you can prep because a lot of times the half-life of THC and CBD is about 6 hours, 4 to 8 hours. So a lot of them have to actually take it twice a day. And then calculate the dose because we prescribe it as milligrams and it's in an oil. So it's and for some reason, my patients can't seem to convert milligram per ml. So I actually print out a page and give it to them and tell them, this is how much you're going to take. Wait 2 to 3 days and take this much more. Or I give them options. Edible cannabinoids again, travel to your stomach, sorry. The combination products during titration phase, if you're combining products, you want to titrate with the THC dose, not the CBD dose. And I prefer to do it separately because they have an interaction, then we'll know which component is causing the problem. So I usually try to start with CBD first because there's no psychotropic effects. I tell them, again, you know, this takes a while before it acts. I tell them to try to take it an hour or two before their medications. And since it's a lipophilic compound, to take it with something fatty like peanut butter, coconut oil, wait an hour or two, then take their other medications. And that's the end of the presentation. These are the references. If you're interested, I can give them to you. So these are contact emails. This is actually one out of, I think it's 6 lecture that my capstone group did. Courtney is a physical therapist, Will is a consultant, Tesserae is a consultant, and Angela is a retired pharmacist. And I asked them if I could share their email. So if you ever have questions or concern, or you know how patients love to bring in things and say, I was told to ask my doctor if this is okay. And if you have no idea what it is, then I probably won't know what it is either. And I do have 2 CBD companies that are not in Texas, but I trust them more than other places because they have third-party testing, which they then put on their website. So you can look up the lot number that you purchase. And then they also have edibles and tinctures. And again, I recommend tinctures because you can adjust the dose better. That's Lazarus Naturals and Charlotte's Web. Charlotte's Web tends to be more expensive and Lazarus Naturals has a discount for patients with lifelong disability. So as long as they have a note from their doctor, they can get a discount. So those are the 2 companies I prefer that I've had other professionals recommend as well. Because I belong to 2 professional organizations of cannabis physicians, and those are the 2 that I recommend. Again, I highly discourage patients from buying any of their CBD or cannabis in a store on the corner because I have no idea what's in it. And I tell them basically you wasted money on either CBD or junk. I just don't know. So any questions? I know it's a lot of information. I can make the slides available. Yes. Let me give this to you. All the time.
Like how to believe that, let's say if they have or like persons to buy. When you say with CBD and you don't like stay away from that.
The question is, CBD tends to have THC in it, and is absolutely correct, and that's why I don't recommend any of my patients getting CBD anywhere unless it's a dispensary, because even the dispensaries have bought CBD from different reputable places and done testing, and they've noticed different quantities of THC. So if it's pure CBD, and I know it's pure CBD, then I don't have problems prescribing that to patients who have family history of psychiatric disorder, because there have been many studies with CBD showing that it does not have psychotropic effects. And again, like you said, I have no earthly idea what's in a lot of the mixtures that are sold. So unless it's done, unless it's bought by a reputable place or it's a medical dispensary, I don't recommend it. And I'm very particular because you're right. I've had patients take Delta 8 and tell me they couldn't handle it because it made them feel very strange. And I don't know how much THC in it as well. And in the state of Texas, minors can be on the PERT program as long as the parents sign, again, because it's a minor. But if there's, that's why we are the best advocates sitting down with patients. So I have patients who have psychiatric disorders in their family, especially schizophrenia. I tell them people start, and of course, sometimes go ahead and do that. But if there's any hint of it in the family, because this is an add-on, this is not a cure-all for everything. And it's just another tool in our toolbox. So I'm still a board certified family physician, so I still prescribe what's recommended by the FDA first for my patients. Who need something else or have not been able to do well, like our son, then I will consider it. And so I'm very cautious also about some of these because I don't know how a physician is certified. I'm cautious about who my patients see. For instance, I had a patient who didn't know I was certified because I don't really promote it. And again, it's just another tool in my toolbox. She came in and she said, I went online and saw a doctor and I paid $200 out of pocket for a 10-minute interview with this physician who told me to go pick up a bottle at one of the dispensaries. So it was a medical grade THC and said, take half a dropper full and increase it till you feel better. The patient was also on ketamine infusion and Vyvanse. And I said, did the doctor know that you were on these two medicines, that you have a pain doctor who does your ketamine infusions? She said, well, he said he had my records, so I guess so. And I asked her, well, did he tell you how to take it, how to dose it, when to take it? No. So my 15-minute visit became 45-minute visit because I spent about half an hour to cannabis dosing regimen. To go pick a doctor, making sure he knew she was on it. She said, I think he knows. Well, don't you guys share information? And said, we usually do, but I don't know who the doctor is. So, and basically, what I did was I went online to find cannabis physicians, and there's a list of them. I'm actually not listed. You can choose not to be listed. The CURT site, and I chose not to be listed because I just wanted to treat my patients. But they're all online. You don't really know what kind of training they have. I think I'm the only physician in the state of Texas with a master's degree in medical cannabis who can prescribe cannabis. I know that another doctor needs to get the degree, but I don't know what kind of training these doctors have, nor do I know. Because again, we don't know how they got certified because there's no the DPS site that says these are the regulations to get certified. Any other questions? Yes, sir.
You would mention actually to testing. So what exactly are they doing with animal and what's the schedule?
According to Texas State Medical Board, there is no guideline to test as long as you test. So I try to test before I start, and then when they come back test them again, and then after that, I try to do random testing, which is in all the six. Slide patients are they can't do so I try to test them 3 times a year. One, make sure they're taking it, and then make sure they're not taking anything else. And actually, my patients on controlled meds, I found that they take the cannabis, I'll ask. And I use it instead of making them feel badly for taking it, I use it as a teaching point, saying, hey, what do you take? Absolutely. But it's, I've discovered that more people are taking it than me. But usually, I usually test 2 or 3 times a year. Just like I do with all my controlled meds.
So I think it's pretty self-explanatory, things like disorder. So there's a big problem influence for all of those. But I worry about PTSD because it's such a broad, nebulous thing. And long-term treatment. What kind of failure is you see, or what kind of crossovers? Those things. In the on other substances. Require increased doses. What kind of is not? I think that really hard.
And I noticed that there's a lot of big studies, so it's still trial and error. And most of the ones that I do see have already been on, and I mean, they can list every medicine to them, every second control they've been on, it's like azabam. Psychotropic effect. I don't start them out on THC. But let's try some THC first and see how you do on that, and kind of go up to a dose or they go, because I have some patients on 400 milligrams 2 times a day, and they're fine. If they need more, I might add a bit of THC. But those patients, because I know their history and their success, I tend to not go with THC, so that because I call them very closely. And I don't take them off their medicine. I tell them this is just another medication. They may not know. My PTSD patients. But again, there's just not enough data. Yes. This is the little girl picture. She is right there. How fair is it when you have you're 6'5" and everybody can stop at you? Well, now it's fair. But when he was going through puberty. Scary, the woman of puberty. And he is scared of his sister. And she's little and there isn't, because again, it's illegal quickly, so there's, you can try, there's a thing. And for was, and again, the testing that I do, the screening is not on patients. But because it's controlled by the FDA, you can actually call them against her. They're not easy to do. I believe.
But then it would be nice if they were somewhere else. And so, I did forget, so basically, if you want to go to another position to serve, be certified to prescribe it to you, because you say from Dallas, San Antonio, the original doctor has to take you off of their list before that we can add to the list as a signal. What else? If you leave the country, depending on what country you go to, you can probably get it easier. Mexico, you can get it, except I'm quite sure how they make it because it's not. Okay, decent dispensaries. So can you travel across state lines with CBD? Yes, you can, but you shouldn't, because as we discussed, we have no idea. So it's considered and federally. Find a dispensary there because they have recreational use and try to find a place that's reputable. Buy it from there. I'm sorry, it's gonna be expensive, but you usually don't need a prescription for those places, so. Any place that has the all for city use it recreational, you can find it. But again, I have, being part of professional organization, I can usually do a search and ask what physician and what state works the best place. My patients who are traveling to be able to pick up their medications and children. Structure, and we can figure out when he's gonna have a meltdown. And he kind of, as I said, medicine. We've had success, we just got back from Canada last week. So, yeah, it's just another tool in the toolbox.
Again, thank you very much to Mary for doing that important talk. We're very happy to have you there.